Good morning, everyone, and welcome to Common Spirit Health Clinical Grand Rounds. It's great to have you here. My name's Tom Frederickson. I'm the System Vice President for Hospital Medicine Operations in our physician enterprise. I'm the co-moderator today with Dr. John Morelli, who will be introducing himself here in just a moment. And I'd like to point out that today's topic is delirium. I'll introduce our speaker here in a minute, and it's a wonderful topic. It's part of our age-friendly Grand Round series. There'll be a couple of other installments coming up in the next couple of months. We're excited about it. And I'd like to point out that it's Mental Health Awareness Month. So certainly a wonderful and important topic anytime, but especially during Mental Health Awareness Month. I'm very pleased to introduce our main speaker today, Dr. Rajesh Tampi. Dr. Tampi is the tenured professor and chairman of the Department of Psychiatry and the inaugural Bhatia Family Endowed Chair of Psychiatry at Creighton University School of Medicine and at CHI Behavioral Health Services in Omaha, Nebraska. He is also a professor of psychiatry at Yale University School of Medicine in New Haven, Connecticut, and is the inaugural historian for the American Association of Geriatric Psychiatry, where he is also past president. I'm going to turn it over to Dr. Morelli to introduce our panelists, and then on to Dr. Tampi.
Great, thanks, Dr. Frederickson. And again, reiterate some of your words. Thank everybody for joining today for, I think, a very apropos topic, not just because it's Mental Health Awareness Month, but really, really germane to the work that we do in our acute hospital space. So it's my pleasure today to introduce our expert panelists. First, we're going to have Dr. Nikhil Seth. He did his medical residency and residency training at Texas A&M College of Medicine. He completed also a fourth-year chief residency in Central Texas, a VA hospital, where he created a brand new simulation curriculum. Also established a transition of care from inpatient to outpatient program, and has published multiple papers on his educational efforts. He's now practicing hospitalist at Houston Medical Center and focuses on high value and evidence-based care. Our second panelist is Connor Rowan, a pharmacist, a clinical pharmacist at Virginia Mason Medical Center. His practice primarily focuses on neurology and pain management, and his professional areas of interest are mental health and mood disorders. So quite esteemed panelist, very expert in this field, so I'm sure they'll be able to offer some excellent insight after our presentation. So without any further ado, I'm going to go ahead and turn this over to Dr. Rajesh Tampi to start off the conversation on delirium management. So Dr. Tampi.
Thank you, Dr. Morelli, and thank you, Dr. Frederickson, and good morning, everyone. I'm going to share my slides now. Thank you. So we're going to talk about the assessment and management of delirium among older adults. As Dr. Morelli and Dr. Frederickson have said that it is a very, very important topic, especially in the care of older adults. Disclosures, as you all probably know, there are no FDA-approved medications for the treatment of delirium among any population, including older adults. And so all medication classes that I will be discussing at the end of the presentation are actually off-label in their use. Personally, I have no conflicts of interest to disclose for this particular presentation. The objectives are fairly straightforward for this presentation. I'm going to talk a little bit about the epidemiology, then talk about the assessment, and then the evidence-based management or treatment of delirium among older adults. The concept of delirium is not new. For the past 2,000 years, people have noticed what delirium is. And delirium actually means off track. And that term was used for the first time in the 2nd century AD. The Greek physicians realized that delirium was a common condition, and they thought that it happened because of inflammation of the diaphragm, which they thought was the putative seat of consciousness in human beings. They also coined the word frenzy, which comes from the word phrenitis, or meaning the diaphragm. They also recognized that there is a quiet form of the delirium, which they termed as lethargus, and from which the word lethargy comes in. It was in the 19th century where the French physicians of Dupuytren, Bonhoeffer, and Chaslin who first realized that it is a syndrome of different symptoms that are occurring in this condition. And they identified chaotic thinking, clouding of consciousness, and cognitive failure as being the hallmark of the delirium state. What they also recognized is that delirium is different from dementia because delirium is a potentially reversible condition. So where are we after 2000 years? Delirium is still a very common condition, especially among older adults and especially among those who are physically ill. It still has very high morbidity and mortality rates. And even to this day, despite significant progress in diagnostics and treatment, delirium is often under-recognized and undertreated among older adults. Why are we making delirium such a big deal? Because we know that irrespective of the baseline patient characteristics and etiological factors, delirium is a poor prognostic outcome for patients. It increases the risk of aspiration, pressure ulcers, pulmonary embolism, dehydration. It is also known to worsen cognitive decline, especially among individuals with Alzheimer's disease. Delirium is a very costly illness, as you will see in the next slides. It increases nursing time for patient, it increases per day hospital cost, and it also increases the length of hospital stay. It not only increases the decline in cognition among individuals with Alzheimer's disease, it is also an independent risk factor for dementia. It increases the risk of institutionalization and death, irrespective of the patient's age, sex, comorbid illness, severity of illness, or baseline dementia. It definitely increases mortality among older adults. Older adults with delirium are about 5 to 14 times at greater risk for dying in the hospital, with 25% dying within 6 months and 39% being dead within 2 years. Like I said, it's a very costly illness. It costs Medicare about $6.9 billion per year on hospital expenditure. Delirium is cost of caring for patients with delirium is 2.5 times more than the cost of caring for patients without delirium. The average cost attributable to each episode of delirium is between $16,000 and $64,000. Overall, the cost to the healthcare system in the United States at the present time is about $38 billion to $152 billion, with the cost being greater than the cost of caring for hip fractures in the US and non-fatal falls, and similar to that of the treatment for diabetes. So it is a very expensive illness, which has significant morbidity and mortality among older adults. How common is delirium? Delirium is more common in acute care settings, including hospitals. The prevalence is about 14 to 24% among older adults who are admitted to hospital. During hospitalization, the prevalence rate is about 6 to 56%. Among post-operative patients, it is about 15 to 53%. And in intensive care patients, it is between 70 and 87%. That is why delirium used to be called as ICU psychosis, because it was so that common among patients who are in intensive care. In the nursing home and in post-acute care, delirium is highly prevalent, with up to 60% of the older patients presenting with delirium. In the community, the prevalence luckily is less at about 1 to 2%. So it's mainly seen in acute care settings, and more acute the setting, more the incidence and prevalence of delirium among older adults. What are the clinical features? On your right-hand side, I have put the DSM-5 diagnostic criteria, but it's easy to think about delirium as a syndrome. That means a combination of multiple different symptoms, which includes acute onset of symptoms. So delirium occurs between hours to days, rather than dementia, which occurs from days to months to years. It has a fluctuating course with inattention. It is not fluctuating course or disorganized thinking that is the hallmark of delirium. It is the inattention that is the hallmark of delirium, as you can clearly see in the DSM-5 diagnostic criteria. So it is associated with significant inattention, disorganized thinking, altered levels of consciousness, with patients being more awake at night and more sleepy during the daytime. It is also associated with cognitive deficits. Patients present with significant perceptual disturbances, including visual hallucinations. There is also psychomotor disturbance. So patients can have the agitated form of delirium, or they can have the retarded or lethargic form of delirium. It's also associated with altered sleep-wake cycle, where patients are more awake at night and more sleepy during the daytime. And it's also associated with significant emotional disturbance, where patients may be presenting with anxiety, agitation, depressive symptoms. So that is the usual clinical features of delirium. How can we classify the subtypes of delirium? You can classify based on motor activity. You can have the agitated subtype, or the hyperactive or the hypervigilant subtype. It is the most commonly recognized form, and it is often due to either drugs prescribed, effects of prescribed drugs, or effects of substances of abuse. So it often happens in intoxication states or drug withdrawal states. Somnolent, or the hypoactive form of delirium, is the most prevalent type, but not the most commonly recognized. Hyperactive is the one that is most commonly recognized, although hypoactive or somnolent type is the most prevalent type of delirium. It is often associated with metabolic conditions, including hepatic and renal encephalopathy. There is a mixed hyperactive, hypoactive type of delirium, which is considered a significant risk for morbidity and mortality among older adults. You can also see other subtypes of delirium, which include subsyndromal delirium. This is a state where patients present with some of the symptoms of delirium that I had enlisted earlier, but they don't present with the full clinical symptoms. Very common in older adults, and it is associated with greater morbidity and mortality. Then we have the persistent delirium. Remember, we are all taught in medical school that delirium is a reversible condition. But in certain patients, delirium symptoms can persist. These patients present with some of the symptoms of delirium that present for weeks to months at a time. Very common among older adults, and is again associated with greater morbidity and mortality. Nocturnal delirium, also called as sundowning, is where individuals present with significant behavioral problems as the sun goes down. So more in the evening times, about the 4 to 7 p.m. time. This is often seen with neurodegenerative disorders, including dementias and Parkinson's disease, usually associated with circadian rhythm abnormalities because of the changes in the hypothalamus of the individual. It is associated with significant sleep fragmentation, and it is one of the most common reasons why there is caregiver burden and burnout, because the caregivers have to deal with the significant agitation and confusion, especially in the evening time. You have to differentiate delirium from dementia and depression. Three common ways of differentiating is: delirium is an acute condition. It happens over hours to days, whereas dementia happens over weeks to months to years. Depression happens over days to weeks. In individuals with delirium, disorientation is profound, whereas in both dementia and depression, and dementia, especially if the patients are earlier stages of dementia, they're not often that disoriented. In depression, patients are often not disoriented. Impaired attention is the hallmark of individuals with delirium. It is not often seen in patients who are mildly demented. It is not often seen in patients with depression unless the patient is profoundly depressed, and in patients with dementia if they are profoundly demented. So acute onset, profound disorientation, and profound impaired attention all point towards delirium, which is an acute condition. What are the etiology and risk factors of delirium? Remember, unless proven otherwise, delirium has a multifactorial etiology. In 85% of the cases, you have multiple different reasons why an older person may become delirious. There is an interaction with predisposing factors, that means a vulnerable patient, with precipitating factors, which includes noxious stimuli, infections, and so forth. When the predisposing and precipitating factors come together, that's when an older adult becomes delirious. For example, the predisposing factor may be older age or dementia, and the precipitating factor may be a change in medication or an infection. Among the predisposing factors, age and pre-existing cognitive deficits, including a diagnosis of dementia, are major predisposing factors for delirium among older adults. Sharon Inouye and her colleagues found that vision impairment, severity of the illness, cognitive impairment, and abnormal renal function are all indicative of a predisposing factor for delirium. More number of predisposing factors, greater the risk of delirium happening in an older patient. What about precipitating factors? Inouye and Charpentier identified 5 independent precipitating factors, and you have to be paying attention to these. These includes physical restraints. That's why restraining older adults in medical or psychiatric units is not a good thing, because the risk for delirium is very high. The relative risk is about 4.4. Malnutrition is another precipitating factor. More than 3 medications added. That is why injudicious polypharmacy is not a good thing for older adults, because they put the patient at higher risk for delirium. Use of bladder catheters is a very important risk factor for developing delirium among older adults. Any iatrogenic event can also predispose an older adult to developing delirium. More number of precipitating factors, more number of predisposing factors, the risk of delirium gets higher and higher. What about drugs that may cause delirium? As a geriatric psychiatrist, for me, patients, when given multiple different drugs of any type, can increase the risk of delirium. So any drug can cause delirium in older adults. Main culprits are benzodiazepines, pain medications, Parkinson's disease medications, antihistamines, anticholinergics. These are things that can cause, often prescribed among older adults, and cause increase the risk of patients becoming delirious. So be very careful when you prescribe medications to patients. So that is why medication reconciliation is a very important thing, especially if you take care of an older patient. What about neurobiology? I'm just going to briefly summarize. There are neuroanatomical, neurochemical, and neuroinflammatory changes that are occurring during the onset of individuals with delirium. Atrophy of the brain and white matter lesions, including strokes, can cause increased risk of delirium. Patients with delirium usually have slowing of the brain functioning. That is why the chaotic thinking and disorientation happen. There is widespread dysfunction of neural tracts, and that is why it used to be called as organic brain failure, because the brain doesn't function well. Neurochemical changes are also observed, especially abnormalities of the cholinergic system, where there is decline in cholinergic function, precipitating cognitive impairment associated with delirium. Excessive activity of dopamine, especially when you give dopaminergic drugs for Parkinson's disease, that can also alter the neurochemistry within the brain and precipitate delirium. Abnormalities of the other neurochemicals are also commonly seen, including norepinephrine, serotonin, GABA, glutamate, and melatonin. Neuroinflammation is also a common pathology within individuals with delirium. What we also know is chronic stress states, where there is increase in cholesterol levels, increase in cortisol levels, can increase the risk of delirium in older adults. Chronic hypercortisolism is a big risk factor for not only delirium, but also for cognitive decline and dementia. What about recognizing delirium? Delirium is often noted because of disorientation and inappropriate behaviors in the patient. However, in older adults, it is often either overlooked or misdiagnosed as a depressive disorder, psychotic disorder, or due to dementia. So again, remember, acute onset, chaotic thinking, disorganization, and inattention are all hallmarks for delirium rather than dementia or depression. What we know to date is that up to one third to 2/3 of patients, older adults with delirium, go undiagnosed by patients, undiagnosed by physicians. So it is very, very important that you pay attention to the patient when they are being admitted to the hospital, because it is much more common in acute care settings. We also need to start using standardized tools, and confusion assessment method in my research and publications has been found to be the best sort of tool to diagnose delirium in any older adult. So the confusion assessment method was actually developed by Sharon Inouye and colleagues when Sharon was at Yale School of Medicine. It was published in 1998, and it has 4 basic elements to it. You look at the patient and you get information from the collateral sources and see if there is any acute onset or fluctuating course for the patient's symptom. You review whether the patient has significant inattention. You look for disorganized speech and altered level of consciousness. And if you have the first 2, that is acute onset and fluctuating course, plus inattention, then either 3 or 4, that includes disorganized thinking or altered level of consciousness, then unless proven otherwise, the patient is delirious. Confusion assessment method has a sensitivity of 94 to 100%, specificity of 90 to 95%, with positive predictive value of over 91 to 94%, and negative predictive value of 90 to 100%. So it is a tool that'll help you diagnose delirium almost all of the time. So you should be doing that in every geriatric patient who's being admitted to the hospital. It should probably be done in the emergency room while the patient is awaiting admission to the hospital, because admission to a hospital in itself is a risk factor for developing delirium in older adults. There are other scales that you can use, but they're not as commonly used as the confusion assessment method. These include delirium rating scale, memorial delirium assessment scale, and the knee confusion scale. But my recommendation is to do the confusion assessment method because it is fairly straightforward and it takes less than 5 minutes to complete. And it can be done by any healthcare professional, including nurses. So prevention. Prevention is the name of the game when you come to assess and treat delirium in older adults. If you can prevent delirium, you're doing a great service to the patient and their families and to the healthcare systems. We know that 30 to 40% of cases of delirium are preventable. Multi-component targeted risk factor intervention, or the MTI, which includes targeting 6 risk factors. These include cognitive impairment, sleep deprivation, immobility, visual impairment, hearing impairment, and dehydration, will reduce the incidence of delirium among older adults. So these, again, should be targeted when the patient is getting admitted to the hospital. Use the confusion assessment method, use the multi-component targeted risk factor intervention method. You will reduce the incidence of delirium. And a study was done which looked at these 6 risk factors, and what the investigators found that you can reduce the incidence of delirium up to half. But what also you can do is you can reduce the number of days of delirium in hospital admitted patients, and you can reduce the total number of episodes of delirium. However, once the delirium starts, you cannot reduce the severity or the recurrence rates of delirium. Hence, prevention is the name of the game in managing delirium among older adults. It has some cost savings. It saves about $831 per hospitalization and up to $10,000 during the lifetime of the individual after the episode of delirium. So again, it is a cost-saving measure, and it also prevents the incidence and the duration of delirium. What about other strategies? Can you do other things to improve delirium? Absolutely, you can. Multiple different studies have looked at that. Early rehabilitation at home reduces the incidence of delirium in older adults. Proactive geriatric consultation has also been shown to reduce the incidence of delirium. Any intervention to reduce the incidence and risk factor of delirium has been shown to be beneficial. So multi-component intervention, early rehabilitation, proactive geriatric consultation, all, if you initiate them, they can reduce the incidence of delirium. You don't have to do all of them. Even one of them is good enough. Some meta-analysis have also shown that pre-treating older adults who are before surgery can reduce the incidence of delirium. My team looked at using melatonin and rebellion, and we found that using these drugs can reduce the incidence of delirium among older adults. We also looked at using cholinesterase inhibitor, and we found one study for donepezil and one study for rivastigmine, which showed some benefit in reducing the incidence of delirium among older adults. So there are multiple ways that you can reduce the incidence of delirium, both non-pharmacological and pharmacological. This is a simple strategy. This is what I had developed when I used to run an inpatient geriatric psychiatry unit. What you want to do is you must target those 6 risk factors of delirium, including the disorientation. So you reorient the patient to time, place, and person. Provide proper sleep hygiene. Try to avoid high potency hypnotic medications because they can precipitate the incidence of delirium. Herbal teas, relaxing music, massage, reduce noise at night can improve sleep in older adults. Adequate stimulation, early rehabilitation, getting patients to walk, doing more activities are all helpful in reducing the incidence of delirium. Avoid bed rests. Bed rests are really bad for older patients. So try to get patients to be more active, mobilize as soon as possible, avoid restraints as much as possible, provide adequate nutrition, provide dentures, staff assistance during meals, get their glasses, get their hearing aids. All of those will reduce the incidence of delirium among older adults. And I had this printed out, and our nurses would make sure that they followed this, and it really did show a significant decline in the incidence of delirium on our inpatient geriatric psychiatry unit. Remember, delirium is a medical emergency. It is ideal to treat delirium on medical units. We treated delirium in geriatric psychiatry unit because there was no other place to treat these patients, and patients and their families wanted me to take care of them. But ideally, it should be treated on a medical unit. Goal is to work on reducing the precipitating factors for delirium in older adults. And there are 4 key steps in the management. First, identify and treat underlying causes. Provide environmental and supportive measures. Prescribe medications for managing behavioral and psychiatric symptoms only when non-pharmacological management has not proven to be beneficial. Review patients regularly, follow up with patients regularly, and also update the families on how the patient is doing. Evaluation of causes. I'm sure all of you are medical providers, so I don't need to tell you what to do. Usual lab work for an infectious etiology or metabolic etiology is the way to go. Very rarely would you need MRI or CT scans of the brain, very rarely. And I have not even done it in any patient of mine where you need an EEG to help. But if you have a patient who's in status epilepticus, is older, well, you probably may need an EEG to prove. But other than that situation, usual lab work is what is needed for assessing and treating the underlying causes of delirium. This is from my paper where we had this algorithm of evaluation and of delirium. Good history, appropriate physical examination, appropriate lab work, complete the CAM or the CAM ICU if the patient is in ICU, and confirm the DSM-5 diagnosis of delirium. General rules and management, very, very important. And all older adults should have this when they're getting admitted to the hospital. 1, you use environmental and supportive measures. Treat underlying conditions. Medications, especially psychotropic medications, should only be used for symptomatic management and when non-pharmacological management, like the multi-component interventions, fail. Avoid injudicious polypharmacy. Don't throw the kitchen sink at the patient because the patient will not do well. Start low, go slow, don't keep on going, because there is a tendency for us to overprescribe medications, which is not good for older adults. Use medications that have proven efficacy. Don't use benzodiazepines. There is no evidence that benzodiazepines are efficacious. Monitor closely. You may need to see the patient multiple times during the day. Make sure that somebody follows up at night with these patients to see how you're doing. But the goal should be preventing delirium. So try to act on those 6 risk factors for delirium and minimize the incidence of delirium. Pharmacotherapy. I know I'm preaching to the choir, but I would just make this statement again. Pharmacotherapy should be mainly used to target the underlying precipitating factors or causes for delirium. You may need to use psychotropic medications for treating behavioral symptoms associated with delirium, but it should only be used when non-pharmacological managements are either unhelpful or partially helpful. So here is a list of medications that have been shown to be beneficial for individuals with delirium. Antipsychotic medications, both typical antipsychotic medications like haloperidol and atypical medications like risperidone and olanzapine or quetiapine have been shown to be beneficial. Cholinesterase inhibitors, some benefit. Our systematic review that we did found one study for donepezil and one study showing benefit for rivastigmine for delirium. Benzodiazepines, not found to be beneficial for delirium. One study showing that Precedex or dexmedetomidine is significantly better than alprazolam. Systematic reviews have been done to show that the efficacy of atypical antipsychotic medications is only as good as typical antipsychotic medications. So is haloperidol the gold standard? I'm not advocating for that, but in my experience as a geriatric psychiatrist, I have used it for 25 years. We use very small doses of haloperidol. We use it with frequent monitoring for both efficacy and adverse effects. We use it for very short period of time. And I have found it to be highly beneficial when non-pharmacological management for behavioral symptoms of delirium have not been beneficial. Haloperidol has been an effective enough drug for it to be used. The advantages, according to me, are it can be given orally, intramuscularly, or intravenously. If you're going to give it intravenous, you need telemetry monitoring because QTC prolongation becomes an issue. It is not all that sedating at the doses that we use, and it does not suppress the respiratory drive. It has fairly few anticholinergic side effects, and it does not have any active metabolites. Disadvantages, if you're going to use whopping doses of haloperidol, extrapyramidal symptoms like Parkinsonian symptoms, dystonias, akathisia all become a major issue. Again, if you're going to use high doses, QTC prolongation and torsades become a risk. So, and if you're going to go use it parenterally, you have to, if you're going to use it intravenously, you have to do telemetry. And it is quite sedating if you're going at high doses, but not at the doses that we use in geriatric patients. Now, are atypical antipsychotics any better or worse than typical antipsychotics? Absolutely not. The evidence suggests they're all equally effective. The way I use these medications is I use it when haloperidol has not been shown to be beneficial, when patients have either allergies or have had failure to the haloperidol, or if you want to give IM or IV medications, and if you don't have IM olanzapine or IM ziprasidone, then you can use haloperidol. I also use atypical antipsychotic medications like quetiapine in patients who are severely agitated from the delirium, and they have either Parkinson's disease or they have dementia with Lewy bodies. So those are the situations that I would use atypical antipsychotics like risperidone, olanzapine, or quetiapine. But again, you should not be using these medications unless you have tried the non-pharmacological management first and they have failed. And only these medications should only be used for short periods of time and with clear monitoring for benefits and adverse effects. There was a recent meta-analysis that looked at using psychotropic medications, and they found benefit for atypical antipsychotic medications haloperidol, Precedex or dexmedetomidine, and melatonergic agents like melatonin or ramelteon. Again, the data that I had shown before was proven in this new meta-analysis. Here are the doses of medications that I use for my patients. This is based on my research and publications. And as you can clearly see, these are very small doses of medications, and we only use it as needed for short period of time with clear monitoring for benefits and side effects. Here is again an algorithm for treating delirium in older adults. It is very simple. We treat the underlying medical or neurological conditions. We manage the drug withdrawal or drug intoxication. We use the non-pharmacological management, the multi-component intervention. We try early rehabilitation, reorientation, and all of that. If patients don't settle with that, then we discuss with the family to see if psychotropic medications are appropriate. After discussion, we use psychotropic medications. It could be haloperidol or any of the atypical antipsychotic medications. And we treat very carefully with modest doses, with careful monitoring of effects and side effects, and constantly update the families on how the patient is doing. But I would recommend, as like I have done earlier, prevention is the name of the game, and it is a team effort, not an individual effort. Prevention of delirium starts the minute the patient hits the emergency room. You do the multi-component intervention with the CAN, and then try to prevent the incidence of delirium, and only use psychotropic medications at modest doses for a short period of time with frequent monitoring of efficacy and adverse effects, and always keep families front and center, because they will be very distressed when their loved one has delirium. So I think that is the end of the presentation, and I'm going to stop sharing and we can do the discussion. Thank you.
Thank you very much, Dr. Tampi. That was wonderful. We really appreciate it. And it's now we have a chance to have a little bit of discussion. So I'm going to start us off with a question, and I'll address this first question to Dr. Seth, but we certainly like Connor and Dr. Tampi to weigh in as well. And so we heard that the burden of delirium is very high and it's very common. The burden is high in terms of morbidity, mortality, cost. And Dr. Seth, you're seeing this every day on rounds. You already mentioned that. So when you think about prevention, can you comment a little bit about what you think the most important interventions are, and maybe some interventions that you see missed every once in a while? And then also maybe a little bit about how you involve the interdisciplinary team, how you involve nurses, therapists, social workers, learners, and others to help in this prevention effort.
Wonderful. Thank you. And thank you, Dr. Tampi. That was an incredible, incredible presentation. So, first thing I always like to think about when it comes to delirium is trying to put myself in a patient's shoes, right? They are normally functional at home. They start their day with coffee. Maybe they go outside and talk to their friends. Maybe they get to see their family members, talk on the phone. And all of a sudden, you have plucked that person out, put them in a room that only has 4 walls. Sometimes all the shades are down. The lights are low. You're waking them up at all hours. You're giving them medicines at 8 p.m., 12 p.m., or 12 a.m. You're getting vitals at 4 a.m., and everything's thrown off. I think even if you or I were in that position, we would also get delirious. So I think going back to Dr. Tampi, it's really prevention and acknowledging who's at risk for this. And what I mean by that is, as you're doing medication reconciliation, let's say someone's coming in for CHF exacerbation, right? Their diuresis doesn't need to be at 9 p.m. It could be in the morning time, waking hours. The medicine is we use our interdisciplinary team with pharmacists. We can say, hey, how long does medication last? 6 hours? Great. Let me time that. or even so far as, what medicines do we use for infections? Cefepime, we know, can also cause delirium. So really going down that medication reconciliation list, seeing which patients at risk, what family members are with them, are there no family with them? What is their, using the nursing staff to be a guide, right? They're there at the bedside every single moment, every day. They know what the patient's doing. They know if they're getting up or not. So I think going back to, really identifying who's at risk and really catering your care to preventing delirium is the way to go.
Thanks, Dr. Seth. Dr. Tampi or Connor, anything to add to those words of wisdom on prevention and how to involve the interdisciplinary team in prevention?
So, Dr. Frederickson, I'm going to ask Connor to talk first, and then I will give my 2 cents.
No problem. Great presentation. I think it covered a lot of the important things, especially as it relates to medication, considerations. And one of the things that my colleagues and I often do are what we call insomnia consults. And what that means is, how do we actually time these meds? How do we get it to best mirror someone's home regimen? Because like you said, a diuretic at 9 p.m., patient of course is going to be up all night, and we can't really call that sundowning, right? But where I found a lot of, my intervention is actually, okay, well, let's take a step back. What, like Dr. Seth was saying, you know, you're in this new environment. It's loud. You're being poked and prodded constantly. You've got people coming in 3 times just in the morning, and then you got even more, so on and so forth. So really just taking that step back and saying, how do I make this less of this stressful hospital admission where I can, and almost kind of gearing it towards more of a hospital, hotel kind of stay, right? You're here to get better. The running joke that my colleagues and I have is, you don't come to the hospital to rest, but in this population, you especially want to facilitate that as much as you can. So identifying the medications, of course, identifying the timing, but also, again, encouraging that environment of rest and healing as much as you can. So, Dr. Tampi.
Thank you, Dr. Seth and Connor. And for me, any older patient is at risk for delirium. So having that vigilance, having your antenna up to understand that, yes, certain older patients, like people with dementia, are more at risk. And another thing is less is more for geriatric patients. Overzealous treatment of multiple different medications. And, sometimes it is okay not to have a sleep for a day. I mean, who says we cannot? So immediately putting a patient on trazodone or Ambien or any of those overzealously treating puts patients at higher risk for delirium. And giving higher doses of medications. I mean, start low, go slow, don't keep on going. I mean, giving somebody 150 milligrams of trazodone at night is a sure shot way of making them delirious and buying additional time in the hospital and worsening their outcome. When you're young, see, and as a geriatric psychiatrist, for me, I'm a minimalist. I try to minimize medications because the outcomes are so much better that way. And anyhow, older adults come in with 5 to 7 medications, and 3 or 4 of them are not prescribed for them, but they have been taking it for so long and over the counter. So I think less is more, and start low, go slow, don't keep on going, and always having the antenna up for the delirium is the way to go, because otherwise you will miss the delirious cases easily, especially the hypoactive forms of the delirium.
Okay, that's great. Less is more. Good.
Less is more.
Pointers there. Less is more. Start low, go slow. Be willing to stop. Okay,
Yes.
Dr. Morelli, for our next question.
Yeah, I don't see anything in the chat, so I do have a question. And this probably to Dr. Tampi, but also to you, Dr. Seth, since you manage a lot of these patients in our hospital. So we heard from Dr. Tampi that there's a lot of interventions that we could entertain in helping to prevent the onset of delirium. And Dr. Tampi, you mentioned one about sleep deprivation and promoting sleep hygiene. But I think one of the things that we encounter, and I'm sure you've encountered frequently, Dr. Seth, is that when patients are in the hospital, it is hard to kind of get them comfortable enough to be able to relax and sleep, despite managing the medication regimen appropriately and support. What do you do in those circumstances when the patient is not sleeping, or you can't intervene on some of these other preventative measures, but yet there's interactions from nursing staff, for example, concerned about the patient? But beyond that reassurance, what other interventions have you found to be helpful to kind of help induce treatment of some of these preventative factors?
Yeah, and so thank you, Dr. Morelli, for that very important question. So the way I approach it is, as Dr. Seth pointed out, the patients have a routine at home. When they come into the hospital, the routine is completely disrupted. So try to mirror the routine as much as you can. Again, longer lengths of hospital stay are not good. So the minute the patient is ready to go from the hospital, you should be trying to getting them out and trying to getting in rehab either at home or at a place. When the patient is there, all the other things that are important, vision, hearing, ambulation, sleep management, dehydration, constipation, reorientation are all simple strategies which will reduce the incidence of delirium. If you want to use medications, and this is a presentation I do all the time, is on insomnia among older adults. And clearly the evidence suggests that non-pharmacological managements are cornerstone to the treatment of insomnia among older adults, including CBTI. I know it's difficult, we don't have trained therapists, but simple techniques of sleep hygiene are very, very, very good. If you want to use medication or medication class, you use the one with the lowest possible side effects. So melatonin or Ramelteon are melatonergic drugs. If you want to use that, that might be appropriate. Again, use it for short duration, not for a long time. You may need to use the dual action or DORAs, the dual action melatonin receptor antagonist. You may use those medications, but don't go for medications that have the greater risk of precipitating delirium, like the antihistamines, the anticholinergics, the benzodiazepines. They should be completely no. So it's a logical workup and management of the patient. Try to mirror their usual schedule, minimize disruption. If you want to use pharmacological management, sure, you can do that. So use judicious medication, judicious use of medications, and again, lowest risk to the highest risk, and constantly be vigilant. And constantly engage families and patients in activities and patients in their own treatment planning. And I think these have all helped.
So what you're really speaking to is really the multidisciplinary approach, right?
Correct.
And involving nurses, involving anyone else managing the patient, but also the family and getting the family's input.
And it really does take a village to take care of an older adult. We just, we try to minimize it, but that is true. It needs a lot of people to provide a lot of input.
I think family is one of the things that's really underutilized in the hospital. Getting buy-in from the family to be there, letting them know, hey, your family member, they're starting to be a little agitated at night. Could you help us be there? Or somebody in the family, a granddaughter, anyone, to help reorient, or even just advocate for the patient at night, or even during the day, if they need a little bit of rest, or if they're seeing things that other people aren't seeing. Family buy-in is something I use quite a bit.
Yes, and the importance of the family and making sure the patient has their hearing aids, their glasses, and their dentures. Right. Okay.
So there is a question in the Q&A, and it says thoughts towards shifting lab draws to PM versus early AM hours to avoid sleep deprivation for those most at risk.
And I would add to that, the same thing with vital signs or MedPass.
Right.
And also, Dr. Tampi, is that a strategy that on the geriatric psychiatry units that maybe you follow, that maybe we should be learning from in our acute care hospitals?
And the other thing, when I do the behavioral disturbance and dementia talk, I always say this: a very well-educated team is an excellent team. So educating yourself, educating your colleagues, educating your CNAs, educating your nurses, all about dementia, delirium, depression, so that they know what to do even before they ask you that question. So they initiate preventative strategies from the minute the patient steps onto your unit. So prevention is the name of the game, because once you're intervening, it's already too late, because all the neuroinflammatory process, the neurochemical process have begun, and they act in cascade. So it opens up, and then you're trying to close the floodgates. It's difficult to do. So prevention is the name of the game, and education is the way to prevent.
So Connor, can I ask you to delve into a topic a little more deeply? I think Dr. Tampi certainly made the point that IV haloperidol, those patients need to be monitored for QT prolongation. Can you talk about some of the other things that we should be aware of, or situations that we need to be aware of where we need to monitor our patients for QT prolongation?
Yeah, so especially in the context of, risk factors and medication selection, Haldol, it's a very versatile medication, so we like it. But with that monitoring, especially with the IV administration of it, QT prolongation is of concern. The general risk factors that I kind of adhere to and keep in my mind is, does this person already have some sort of bradycardic, heart block or anything like that may be, or prolonged QT interval as it stands? Do they have chronic kidney disease on dialysis or just at risk of those electrolyte abnormalities? Potassium and magnesium come to mind especially. But again, in the context here of administering these medications, using them in the lower, smaller doses and using them on that as needed basis generally helps to mitigate that. I'll also add, I don't know if anyone else uses subcutaneous route for Haldol as well, but that can sometimes mitigate it a bit more in that regard, and sometimes is a little more tolerable compared to IM if you're able to administer. I think that rambly version was answering the question.
Anything to add, Dr. Seth or Dr. Tampi?
So Dr. Seth, do you want to go first?
Yeah, I completely agree. Working with residents, it's funny because I don't know if there's like a fear of using haloperidol or olanzapine or any more of the psychotropic meds. If people tend to jump straight into, Ativan or Benadryl or whatnot as they're early in their education. So going back to that, I agree that just kind of being educated on the medicines, know what to look out for, but know what's actually beneficial and not beneficial is really helpful.
Not along with starting low, right?
Right. And also only using it when you absolutely need to. So understanding that sometimes less is more. So you only intervene when other things have been tried, and not sort of doing injudicious combination of medications. Don't give drugs which can prolong the QTC, especially when the patient has electrolyte abnormalities or conduction defects or pre-existing. And if you are in doubt, ask a colleague. We should utilize each other as support systems for taking care of the patient. So I always say 2 brains are better than 1, especially when you're in a crisis situation. So the team-based approach also includes other physicians and providers who can help you think through logically as to how to deal with that. It's not the Clint Eastwood way of the Lone Ranger and firing off the things before asking questions. You always do it in a team, and you always ask questions first before you fire. So
I think maybe we have time for one more quick question. I'm going to ask something that I'm kind of passionate about, see what the panelists think. One of the studies you brought up, Dr. Tampi, is that patients rehab better and have a lower risk of delirium when they rehab at home.
right.
So any thoughts about best practices for having that discussion with patients and family members when they may be reluctant to go home?
And so Dr. Seth, if it's okay, I'll do that, and then you can do the honors of ending this discussion. So, for me, it is the discussion with the patients and families begin at the bedside when you first interact with them. So I'm always engaging them. I'm always providing them with the data, and I'm always talking about studies and the evidence, and telling them to have faith in their providers, because when they recommend something, that is the way to go. And I also tell them longer stays in the hospital are not good for all the patients. So trying to get them to a more of a home environment is the best way to go. And recovery sometimes happens best at home, because it's a very familiar environment. And it's I think it's also about trust. And trust begins, and sometimes I've even engaged their primary care physicians whom they trust in that discussion. So again, it's a team effort. It's not an individual effort.
Yeah, I do think that that's actually pretty tough sometimes, especially in hospital medicine, because especially when somebody already has delirium, you have a family member who's asking you questions such as, when is this going to get better? Well, they're delirious in the hospital. I can't take them home like this. They're not going to get better like this. Maybe a facility will be better. So what I've found successful, or found to be successful, is just going back to what are they doing at home and what are they doing here, and using that as a comparison. And, not even really convincing them, just say, okay, at home, they're going to make their coffee. They're going to watch some TV. They're going to talk to you and their friends. Here, they haven't been doing any of those things. So let's try to get them back to the place that they're going to be most comfortable. And usually people buy into that. But I do think those conversations are particularly challenging, because once somebody's in the medical system of going to a hospital and short-term nursing facility or rehab, they want to just stay on that trajectory and not deviate from the idea that, actually being outside of the medical system could be better.
Well, thank you very much to both of our panelists, and especially to Dr. Tampi. This was, I found it very enlightening. I suspect all of you did as well. So, and thank you also to Dr. Morelli for being my co-moderator today. And have a good Friday and a great weekend, and look forward to further appointments where we're going to continue to explore these important geriatric topics.
Thank you very much. Thank you. Have a great day. Bye-bye.